Hi there. Today on the podcast is our 2025 menopause hormone therapy update. And we're having Dr. Kerri Anthony as a guest. Now, I just want to let you know ahead of time that you deserve to have a discussion about this with your own doctor and medical team. If your doctor says, I don't do hormones, I'm afraid of hormones, this does happen because everyone is not trained in perimenopause and menopause. If that happens, it is okay to add another doctor to your team or another provider to your team. So if you go to menopause.org, you can search providers in your area that are trained in perimenopause and menopause and can help you with the issue of hormone therapy. Also, in the episode today, Dr. Anthony will tell us which of the states she has licenses in, so you could also see her with a telehealth visit. So here we go. Hello, my friend, and welcome to the podcast today. I am thrilled to introduce you to Kerri Anthony, MD. Dr. Anthony is an OB-GYN doctor in Oklahoma. Let me tell you a little bit about her, because we're going to be talking about menopause hormones, and this is kind of your 2025 hormone update. All right. Dr. Kerri Anthony is a native of Atlanta, Georgia, and is a board-certified OB-GYN. She received her Bachelor of Science degree from the University of Georgia, where she now serves on the Board of Advisors for the Franklin College of Arts and Sciences. Dr. Anthony received her medical doctorate degree from Morehouse School of Medicine in 2004 and completed her OB-GYN residency at Atlanta Medical Center in Atlanta, Georgia in 2008. Upon completion of residency, she moved to Oklahoma with her husband and 2 children to join a private OB-GYN practice. After 8 years in private practice, Dr. Anthony transitioned to a position as an OB hospitalist at Mercy Hospital in Oklahoma City, where she continues to practice today. Dr. Anthony's true passion as an OB-GYN is in women's sexual health, especially during the perimenopause and menopause transition. This passion led her to found Your Menopause MD, a telehealth platform that provides personalized care for menopausal and perimenopausal women in 17 states. And we are going to tell you what those are at the end. So hang in. If you need her, you might be able to see her virtually.
Yes.
Dr. Anthony is a Menopause Society certified practitioner through the North American Menopause Society. In her free time, she enjoys traveling with family and friends, playing tennis, and curling up with a great book. Welcome, welcome, welcome.
Thank you. Thanks for having me.
So I actually found Dr. Anthony on TikTok, and the reason I found you there was I love bright colors, and your whole vibe of your feed there is super bright colors. And I was like, I think I need to know this woman. So
awesome. Awesome. Well, it's a pleasure.
Well, let's talk a little bit about why do so many women get dismissed or misdiagnosed during perimenopause? And what can they do to get taken seriously?
That's a great question. And, really, I think that's kind of what led me to start my telehealth practice is realizing as a board certified OB-GYN how little training I received in residency. Now I've been doing this for a little bit over 20 years. And, as I entered into my own perimenopausal journey, I realized that we really don't get training. I mean, we as OB-GYNs, we do get a little bit of menopause training, but it's short, it's in residency. There's not really any discussion about this in medical school. And of course, when we're in residency, now we're specializing as OB-GYNs. And, you might have a few patients in a resident clinic who are menopausal that you offer hormones to, but there's no dedicated curriculum for perimenopause. Right. So if patients come in and have that initial symptom, which for many is the onset of an irregular cycle. So maybe periods are getting longer, there is bleeding between periods, or the opposite periods could be shorter. And you see a patient who's complaining about that, you usually just say, well, maybe we can just start a birth control pill. You never address anything hormonal. It's just not part of the curriculum. So now, when patients are going in and seeing PCPs, OB-GYNs, really all of the above, if there hasn't been any specialized training, most of the time what we say is this is a normal part of aging. The irregular periods are normal. Maybe you'll be menopausal soon, or that mood that you're experiencing is normal. It happens after age 40. And you may get offered an antidepressant or an anti-anxiety medication without really having the workup. And it's not just we're dismissing because we don't want to hear about it. It's just the training. We are lacking the training. Right. And so there is certification through the North American Menopause Society, and all specialties are able to go and get that certification where you get education that is really centered around treating perimenopausal and menopausal patients. And I think it's probably a little bit more difficult treating perimenopausal patients because most are still having a period. And so you haven't had that 12 months without a period, which is really what we use to define menopause. And we usually, for those of us who've had just the little basic training, only offer hormone therapy to patients who've gone 12 months without a period. And so there's a big lack of education around the fact that perimenopausal patients can also start hormone therapy.
Right. And there could be 10 years of that before menopause, really, right?
Yeah. So when you think of the average age of menopause in the United States, it's about age 51. Perimenopause, we say, can really start anywhere from 2 to 10 years before hitting menopause. So that puts us at 38 or 39 possibly when we're starting to have perimenopausal symptoms. And really, for me and for most of my patients, the symptoms in perimenopausal, if we have them, are usually a little bit more difficult to manage. They are more bothersome than the symptoms we have in menopause. Because in perimenopause, we still are producing hormones, we're just producing them erratically. So there are some days where your estrogen level may be really high. There are other days that it might be undetectable. And some days it's just where it has always been. But it's that change over day to day or over a 3-day period. It's the rise and fall of the hormone levels that really cause the most bothersome symptoms. And so, that's where we see mood symptoms really predominate here, as well as brain fog. And so once we're menopausal, we're not making the hormones at all. And hot flashes and night sweats are the ones that we think of. Those are short-lived. So we won't have those for the rest of our lives. But the other things that we experience, we may have for many years. And because we're no longer making estrogen, some of those symptoms like, decreasing our bone density and brain fog, those may continue with us as long as we are here if we don't take any form of estrogen replacement.
Right.
Yeah.
And I think there's also, isn't there sometimes a conversation that I'll hear people just when I'm out and about saying, well, it's not really bad enough. I mean, I don't, it's, I don't know that I should go talk to anyone yet because it's not really that bad. My hot flashes that wake me up at night.
I think that, what's helpful in the office setting is just having a questionnaire, right? That you are giving to patients who are 30 and up, or having the conversations during those well visits in our mid to late 30s where we say, now these symptoms may start. You may start to experience, some of these changes. It may be irregular periods. It may be hot flashes. It may be night sweats. And while some of us may experience them and say they're not quite bad now, what else is going to follow those? Are they going to get worse? And are we going to have additional symptoms? And again, sleep disturbances, the brain fog, irritability, anger. Some patients will experience really depressive type symptoms or just tearfulness, for no reason. And it's not just about hot flashes not being too bad. I just carry a fan with me, I'll be fine. Are there other symptoms? And I think just opening the conversation up, like for me, I would like for patients to advocate for themselves and say, when they're in the visit, these are the symptoms I experience. Could this be perimenopause? Could this be what I'm experiencing? Versus, and again, before I had the training and when I entered into my own journey, I thought back on the patients who maybe would have benefited from menopause hormone therapy versus a pat on the back. This is just a period of time. In the next couple of years, you'll be okay if you can just make it through. And I mean, I was there because I didn't have the training either. And, there's just, again, there is a difference for most of us when we start to have those symptoms and don't treat them versus those who treat. And for me, it was night and day. once I started my own menopause therapy with hormones, I was a different person. And that's what patients say. They come back and say, I'm a different person, or I feel like myself again because I was a different person in my perimenopausal journey, and now I feel like myself again. So
Yeah, so good. So we really want to just encourage people that if you're having any symptoms, it's time to talk. They don't have to
absolutely
be bad. It's just time to talk. It doesn't, you're not committed to doing anything. It's time to talk.
correct. Let's talk about all the things that are happening. Let's talk about what's happening to the hormones and talk about all of the options for treatment. And again, you don't have to choose any of them, but we want you to be aware. We want you to have the knowledge so you can make an educated decision when it's time.
Yeah,
Yeah.
thank you so
Yeah,
much.
absolutely.
So, if you could give every woman one lab, one lifestyle shift, and one treatment option to focus on in perimenopause, what would they be?
Hmm. Interesting. So let me start with the lab that I'm asked most about. Well, the labs are hormones, right? So patients
Mhm.
usually will come in and they want to have hormone levels checked.
Yeah.
And what I will say to that is that's probably not the first thing that I would recommend if you ask me what lab I recommend, because the hormones are fluctuating, as I mentioned before. And so in perimenopause, you may have a lab panel drawn for your hormones, so estrogen, progesterone, testosterone, and the lab values could be normal. And so what I would hate is for a patient to go in to someone and see someone and have labs done because they're having symptoms and then receive the call to say, labs are normal, you're fine. You're fine. There's nothing wrong. Because at the moment that call comes in, that could be the day that the estrogen levels are undetectable. And that could be the day that somebody put an empty carton in the refrigerator and you just raged about it. That's not what I recommend. I think that treating perimenopause by symptoms is going to be more important. And it does not necessarily matter if labs are normal or if labs are fluctuating, because we really treat based on symptoms. So the one lab, if I had to pick one, there's maybe two, but it would be we call it a TSH, or a thyroid stimulating hormone. So it's to evaluate the thyroid gland, which is a gland in the neck. And the reason I would choose that one, if it has not already been done, which a lot of times it's part of your annual labs. If you get your cholesterol checked and your blood count checked, we would add a TSH to that. But hyper and hypothyroidism can sometimes mimic symptoms of perimenopause and menopause. So there are patients who they feel like they have a rapid heart rate. There are hot flashes and night sweats, or heat or cold intolerance. Those are also symptoms that can be associated with an abnormally acting thyroid gland, so an overactive or an underactive thyroid gland. So if I had to pick one, if we were in the perimenopausal, menopausal age range, it would be that. And a close second might be, again, we usually check your blood count when we check annual labs, but if you're not going in for annual labs, we don't have that information. So either a hemoglobin or a ferritin level to check your iron stores to see if you're anemic, if you have low iron, because that also can then lead to some of those same symptoms like fatigue or brain fog, even sometimes joint pain. And so a TSH, absolutely, if I had to pick one, it would be that lab to check just the basic function of the thyroid. And if it's abnormal, then we'd add additional labs to kind of tell us where we are with that one. And then a close second would be to check to see if you are anemic or have low iron levels.
And I'd also want to just tell people that, as we have said, a lot of OB-GYNs don't have a lot of training in menopause. A lot of primary care doctors don't have a lot of training in menopause. So I've had people who came and said, my psychiatrist said I need to get my lab checked to see if I'm in menopause. So if someone says that and then your actual menopause doctor says there isn't really a lab for perimenopause because the hormones are going up and down, it's okay. A lot of doctors don't know about the lab work. So they may say that and it's okay that it's not true.
Yes, exactly. And again, if I see a patient through a telehealth visit and we don't have up-to-date labs, I absolutely will say, let's go ahead and get this panel so we know, because what we also don't want to do is say that the symptoms are perimenopause or menopause, and then we treat with maybe hormone therapy or we give estrogen therapy, and we're still having the symptoms because we missed a thyroid disorder or we missed anemia, especially if you're still
Right.
having menstrual cycles. So if you're still having monthly periods or heavier periods, which again can happen as we hit perimenopause, then we may have a lower blood count. We may be anemic, and we need to address that as well.
Okay, so a lifestyle shift, what do you like to recommend?
Okay. So for lifestyle shift, again, there's a few things, but if I had
Yeah,
to
go
pick
ahead.
one, if I had to pick one, I think the most important is prioritizing sleep.
Mm,
So as we enter this journey, most of us are having some type of sleep difficulty, whether it is because we're waking up with night sweats, or if we're waking up with our brains racing, or maybe we don't have great sleep hygiene even going into it. And so this has
mhm.
been our lives. And now that we're hitting perimenopause and the hormones are shifting, we aren't able to really function with the 5 or 6 hours of sleep that we've been functioning with our whole lives. Because for many of us, we've been taking care of a household,
Yeah.
running kids from place to place or working or being everything for everyone else except ourselves. And so we may have been able to function off of 4 or 5 or 6 hours of sleep. But when these hormones start shifting, you can't do it. Like, you hit a brick wall. And so I think it's easy, it's free. We don't have to join a gym to prioritize sleep. We don't have to really buy any supplements to prioritize sleep. But starting with a sleep diary, making sure that the temperature in the room is comfortable, so a
Mhm,
cool enough temperature for you to sleep, maybe white noise, using a meditation app, maybe even light yoga before bedtime.
mhm.
For some, I say even remove the television from the room if there's just that little blue light that emits from the television. And then going to bed at the same time every night, or planning to wake up at the same time every day. Like, there are plenty of online resources to kind of help with shifting to make sure that you're giving yourself really at least 7 to 8 hours of sleep per night. And so I think if we could pick one thing that would be probably most beneficial. Now, of course, exercise absolutely is there. I mean, I think that goes
Mhm.
without saying. But if I could pick one thing that I see multiple patients complain about and we suffer from, it is poor sleep hygiene. Now,
Yeah,
okay,
that's
so
great.
I still have to plug in the exercise.
Yeah, for
Because
sure. Go ahead
because
and say something about that. Yeah.
well, because it's different for us now. We're losing lean muscle mass as we get older.
Right.
We are storing more abdominal fat or central fat because our bodies think, for some odd reason, well, probably because it's true, that we can convert some fat cells into estrogen. Not enough to treat our menopausal symptoms, but our bodies at this point, they're kind of shifting. And so I like to, compare it to maybe a hibernating bear, where we're just trying to store that fat right here in the abdominal area. And so we have to work harder to lose weight. In addition to doing aerobic exercise, which we know is great for the heart. So we really want about 150
Mhm.
minutes of aerobic exercise a week. It is essential that we do some form of weight or resistance training, whether it is doing weights around a circuit in a gym, if it's just picking up, ordering online and having delivered just hand and ankle weights when we're
Mhm.
walking. We see the weighted vests, that's really helping more of our bone mineral density and with balance. But resistance bands, pretty cheap. You can look at, videos on YouTube
Right.
for starters, intermediate, and advanced levels, and just use resistance bands to help kind of build up that muscle. It's essential that we start building the muscle now, because we will continue to lose that lean muscle as we get older. So, exercise, absolutely. I feel like that goes without saying. So, if I had to pick something, that's why I pick sleep priority, prioritizing sleep, because really we should all be getting that exercise in and adding that weight and resistance training.
Yeah. And thanks for
Yeah.
saying that about the sleep too, because I think people are like, "Oh yeah, yeah, sleep's important," but very important at this time. One of your important pillars that you should pay attention.
And
Pay
and
attention.
as an OB-GYN who is used to a lifetime, after training of
Right.
sleepless night, it absolutely is different once we're perimenopausal. I hit that big 50 last year, and it is different. And I joke about it with other colleagues. I'm like, well, I just feel like the overnight shifts where we're up in the middle of the night, I have to recover longer. And it's
Mhm.
because, you know, with this hormonal shift, we respond to those minor changes or those minor deficits in sleep. And brain fog and fatigue are just predominating if you aren't getting, again, at least 6 to 7 hours of sleep. And I was, I'm one who could stay up all night because, again, my career, like I could do it and I'm fine and I'm functioning great. But now the recovery the next day, it's rough. It's rough.
Yeah. Yeah, you're definitely the one to speak to it.
Yes. Yes. There's a before and after when we talk about sleep and perimenopause. There's definitely a stark difference between the before and after hitting these hormone changes.
Yeah.
And I think the last part of this was therapy.
Yeah, treatment options for perimenopause in particular.
So I would stick with the gold standard treatment in menopause, also for perimenopause, which is hormone therapy. So replacing or actually kind of keeping the gas tank half full. When we're in perimenopause, again, we're still producing those major hormones, estrogen and progesterone. But those levels sometimes feel undetectable in the body. And again, symptoms usually are worse when we're on a roller coaster when it comes to hormone levels. And so the gold standard treatment in menopause, when our ovaries are no longer making those hormones, is to replace those with estrogen and progesterone. That is still my first line of treatment when we talk about perimenopause. Many physicians and nurse practitioners will offer a birth control pill, maybe a low-dose birth control pill, because it gives you some estrogen and progesterone. One thing is it's different. It's a different type of estrogen and progesterone. It's not the estradiol that is identical to what our bodies make that we give in menopause. And so it doesn't quite work the same way. It will absolutely help to regulate a period, birth control pills. And birth control pills will absolutely prevent a pregnancy. So, 99.9% effective, for preventing pregnancy. It is not 99.9% effective in treating perimenopausal symptoms. So if the biggest symptom is just I'm bleeding irregularly and I want to control the cycles, absolutely, it's a great plan. It's a great treatment option. But if we're experiencing mood symptoms, if we're experiencing night sweats or hot flashes, which may not be as severe as we think they could be, in perimenopause, I still would treat that with menopause hormone therapy with estrogen and progesterone. Yeah.
Let's talk a little bit about that. Who needs progesterone with their estrogen?
Yeah. Yeah. So if you still have your uterus, you will always need to take progesterone whenever you take estrogen. So estrogen taken alone promotes thickening of the lining of the uterus. And so over time, if we only give estrogen and the lining of the uterus continues to thicken, there is an increased risk for that thickened lining to then develop abnormal tissue, which then could lead to uterine cancer or endometrial cancer. And the step before that is endometrial hyperplasia. So that's why in women who have a uterus, anytime we prescribe estrogen, we always prescribe it with a progestin or progesterone. And that's the same for birth control pills. So if a birth control pill has estrogen, it always has progesterone, where you can also get a progesterone-only birth control pill. That's great, but if you ever take a birth control pill that contains estrogen, it has a partner there, and that's progesterone. The contraceptive patch that contains estrogen also gives you progesterone. The ring, the vaginal ring for contraceptive, estrogen and progesterone. So anytime we ever give a woman estrogen that is systemic, so not vaginal estrogen that we use for vaginal symptoms, that is different, that's considered local estrogen. But anytime we give you estrogen that goes throughout the entire body to treat symptoms like stopping ovulation or stopping hot flashes and night sweats, we always have to pair that with a progesterone. Now, in perimenopause, a lot of patients will come to me with a progesterone IUD in place. If we decide to start hormone therapy, if that progesterone IUD has been in place less than 5 years, it can provide that protection. And so you don't have to take an oral progesterone tablet while using the estrogen to help with hot flashes, night sweats, and perimenopausal symptoms. So it's not necessarily that you have to take a progesterone tablet. If you've got a progesterone releasing IUD, that works just as well. Now, one caveat to that is the major name brand IUD right now can stay in place for up to 8 years as a contraceptive device, but we don't really have the literature to support it for 8 years to provide uterine protection. So if we are going over 5 years, we would recommend having it replaced. And it's we use it off label for that indication. So there's not an FDA indication that says this can be used with hormone therapy with estrogen, but we've got the data and the research that supports it for up to 5 years. So a lot of times I'll have a patient who has a progesterone releasing IUD, and we just add an estrogen patch, so an estradiol patch that goes transdermally, and see them back in 3 months, and symptoms are much better or resolved. So we've got a couple of different options for progesterone.
You've mentioned a few different ways of getting these medications. And so there are going to be choices, right? This will be very customized to you and your
Absolutely.
goals and how your doctor thinks this is going to help you best. With patches and pills and rings, it's just good for people to know that there are a lot of different ways to take these things, right?
And believe it or not, I do still have patients who are unable to swallow an oral tablet, capsule, or pill. And so for them to know that there are additional options if they aren't able to actually take a medicine by mouth, because there are patients who have no idea that there's any other option. So, and actually with estrogen, we prefer a transdermal estrogen anyway, just because the literature supports that taking estrogen transdermally comes with a little bit lower risk of blood clots or clotting than if we take it orally. So the preferred method for most of us who have menopausal training is to offer either a patch, a gel, or a spray. Most of us, me included, we like the patch. It's easy, it's small, it's twice a week, and you don't really have to think about doing something every single day. So
Nice.
yeah.
I'd also, just as we're talking about this, like to normalize a little for people that when they start treatment, it's not like you take a pill and you're better that evening. It's a slow boat to feeling better, right? Would you?
Yes,
Because you
absolutely.
mentioned that you're going to see people in a couple months. So.
Yes, absolutely. If we start hormone therapy and it's a new start, what I usually say is you really have to give the medication at least 2 to 3 months to know how well it's going to work for you. And even if we need to make adjustments, it may take 2 to 3 months to know, yes, this is working, but I might need a higher dose or I might need a lower dose. And so even with the multiple different formulations, we also have multiple different doses. So I usually do a follow-up after 3 months on medication to just touch base and see. We go back over the list of symptoms that we started the initial visit for, and we talk about each symptom. Is this totally resolved? Is it 50% better? Is it 25% better? And then that allows me to kind of have a big picture of maybe we might need to adjust the estrogen here, or we might need to consider adjusting the progesterone. And it is not instantaneous. I will say that a lot of patients will tell me after about 2 to 3 weeks, they notice that something is improving.
Yeah.
But we really don't know for about 2 to 3 months how well it's working and how. Now, hot flashes, sometimes, patients will say instantaneously those hot flashes, they disappeared. Or, you maybe had them 5 times a day and now you're having one a day. So those hot flashes probably are going to be the first thing that we notice a difference with. But really everything else, especially the fatigue, the brain fog, it's going to take feeding the body that estrogen over the next few months to really know, because we've got to get those receptors filled again to really know how well it works. And we can always make adjustments. So I think the other thing is patients are sometimes afraid, okay, well, if I start hormone therapy, then I'm committed to it for life and I can never go off of it. There's no weaning. So if you don't like it, you don't take it the next day. Like there is no weaning process here. Now, if it works for symptoms like hot flashes and night sweats, and maybe we don't like it or we get a little bit nervous and we stop, the hot flashes and night sweats may come back. Now, we don't keep hot flashes and night sweats for life. As I mentioned, for some of us, that might be 2 years of hot flashes and night sweats. For others, it might be 3 to 5 years. But eventually, those will go away. And that is really what menopause hormone therapy is FDA approved for. It's to treat hot flashes, night sweats, and to decrease our risk for osteoporosis. But the reason that most women continue menopause hormone therapy is the beneficial side effects. So these are not the FDA approved reasons to take it, but it's all the things that it helps to improve Again, sleep and mood and fatigue and joint pain and brain fog, mental clarity. It helps with all those things. It helps with the skin. For some, it may help to decrease hair shedding. It does not help to grow hair back, but some may notice a difference because some of us notice a different texture in our hair and just multiple stages of shedding. And so for many of us, it helps with that as well. So there's a whole list of beneficial side effects, which are why most of us say, I'm team hormone therapy for life. But, we do have to weigh the risks as we get older. But most of us, especially those who are menopause trained and are taking hormone therapy, are like, yeah, this is it. This is
Right.
my medicine. So, yeah.
Nice.
Yeah.
And this is a conversation people have with their doctor every year, right? When they're once you're all set and
Yes.
comfortable on what you're on, it's discussing those risks and benefits
Every year.
every
Yep.
year.
And
Yeah.
so we just look at where we are age-wise. We look at family health, any new family medical history, any new personal medical history. Of course, there are some reasons why we might have to stop hormone therapy. So we're looking to see if any of those things are occurring. And usually we're going to talk about those before starting anyway, because we want to make sure that if something changes in the course of that 1 year before you have a visit, that you notify, your physician immediately if one of those things. So we usually are going to have those conversations to say, these are the things that you need to let me know, if they happen while we're taking it, because then we're going to have to make some changes. But yes, we definitely want to visit every year. And really, when I talk about those annual labs, not estrogen and progesterone, we don't have to really do those once a year, but we still want to have the annual lab work where we're checking your blood count and checking for thyroid function, as well as checking the lipid panel and looking at cholesterol levels and seeing if anything is changing there or needs to be treated there. So definitely once a year, and then with up-to-date labs.
Great. And do you want to talk generally about what risks are of hormone
Absolutely.
therapy?
Yeah, we can talk about them. So there's a big study that came out way in the early 2000s, and it was the Women's Health Initiative. And I think most physicians and patients who maybe voice fear about taking hormone therapy, specifically taking estrogen, that fear goes back to when the black box warning was placed in the first place, back when the Women's Health Initiative study was going on. That study enrolled women age 50 to 79, so very range of ages. And the study was actually designed to follow those women for life who either took a placebo pill or patients who took estrogen and progesterone, or patients who took estrogen only because they had had a hysterectomy. Now, what happened in that study is, unfortunately, there were women who were diagnosed with heart attacks and strokes and blood clots in their legs, so DVT or PE, and the study was discontinued. And the black box warning got placed, and it said if you take estrogen, you are at risk for strokes, heart attacks, and blood clots. And so what we really already knew about hormone therapy, one, is that it worked for hot flashes and night sweats. So we weren't testing that. They also wanted to look at other outcomes like dementia and certain cancers. If they followed these women for the rest of their lives, were they going to see any changes by each group? Would we see a reduction in certain cancers? Would we see more cancers, et cetera? So again, the study was discontinued and that black box warning got placed. But we already knew that estrogen really is a pro-clotting hormone. Estrogen in our lives, so women who take birth control pills, women who have pregnancies, women who take hormone therapy. So there are times in our lives where we may have higher levels of circulating estrogen in our body. And we are at a higher risk than one who does not have that level of estrogen for forming a blood clot in the leg or lung. And what we saw in that study is those outcomes happened more in the women who were older. And unfortunately, women were enrolled in that study at 79 and started on hormone therapy for the first time in their lives. And so if we just take the medication out of this discussion and we just compare a 50-year-old and a 79-year-old, and we look at the blood vessels in their body, specifically the ones in the neck and the ones that are pumping those heart muscles, those vessels are already narrow. So we all have those vessels are going to be smaller than the other vessels in our body. But as we get older, of course, those vessels are going to get narrow. We will form plaques, even if we're never diagnosed with high cholesterol and need to be on a statin. Just aging, the benefit of aging gives us those changes. And so if we just look at a 50-year-old and a 79-year-old, the 79-year-old's vessels are going to be more narrow. And so if we give that 79-year-old a medicine that might increase the risk for forming a clot, and a clot gets formed, that clot is more likely to get stuck and block the blood flow to the heart or to the brain because the vessel was already more narrow. Now, what we found, so that study was stopped in the early 2000s, but then we still followed up with these women. So we still followed up with the ones who were available 20 years later. And what we actually found was that the group of women who were started on hormone therapy after 20 years had lower rates of strokes and heart attacks than the group of women who were in the placebo group, the ones who took no hormone therapy. That group of women actually had more women diagnosed with strokes and heart attacks. So now, after 20 years, we've gone back, and now the articles are public. Like, you can find them; they're there, saying that we actually support hormone therapy because there may be a benefit. There may be a cardioprotective benefit that may reduce our risk for strokes and heart attacks only if we started within the first 10 years of menopause and younger than age 60. So we don't want to start new after age 60 unless you weigh the risks and benefits. And there are some patients who choose to do that, but you have to really be informed about how those risks and benefits change after age 60. But what we know, again, team hormone therapy here for myself is that I may get a benefit. I may get a cardiovascular benefit. So we do still say, we can't say that there's no risk. So what we also found is that if we use hormone therapy and we take transdermal estrogen, as I mentioned earlier, so not taking it by mouth where it has to be processed by the liver before it then gets distributed through our bodies, taking it as a patch on the skin or as a gel or a spray, it gets absorbed immediately into the blood vessels under the skin. And so it doesn't have to go through the liver to be activated. Now, the clotting factors are also made in the liver. So what we think is, one, when we take that estrogen by mouth, it goes in the liver. It's in that liver where those clotting factors are made, and that may be why we see the increased incidence of clots when we take it orally. But we do have papers that actually support the fact that we don't see that same risk if we take it transdermally. And that study also gave us questions about breast cancer, because in that study, there was over 160 women in the study. Our risk of breast cancer is 1 in 8, just being born a woman. Just having the female reproductive system in our bodies, we have a risk that's 1 in 8. Can't change that. We can decrease the numbers, but we don't have to get into that. But if we look at that study, of course, because we had more than 8 women, we saw breast cancer, but we saw breast cancer in every group. And what was really interesting is that the lowest incidence of breast cancer in that study was in the group of women who took estrogen only. The highest incidence was in the women who took estrogen and progesterone, and then the placebo group was in the middle. So the placebo group actually still had women diagnosed, and they had more women diagnosed than those who were in the estrogen-only group. It makes us question the study. Were the women in the estrogen-only group, did they also have their ovaries removed at the time of the hysterectomy, which might have lowered that risk? Did we factor out for patients who had a strong family history or a BRCA mutation or any of those things that might have put them at a higher risk? And were they in every group? We just, we don't have all of that information, of course, now looking back. But what we do know is that when we looked at the estrogen and progesterone group, it was about a 1 in 1,000 increase. So we say it's about 1 in 1,000. Remember, we're 1 in 8 just being here. So that risk is really, really low. It's lower than just our lifetime risk if we have no family history and no gene mutations. The other thing is that when they did that study, they used synthetic hormones. They used synthetic estrogen and they used synthetic progesterone. And that's not what we usually use now. So we don't use the estrogen that's made from, pregnant horses' urine. We're not using that type of progesterone. I mean, I still have patients who come to me on those medicines, and we talk about it and try to switch them. But that's the other question, is we're not even using the same thing that was being used in that study. But it's the only study that we quote. Now, there were studies out of Europe that came after that really looked at the progesterone, and they thought the progesterone might be what increased that risk. Again, we don't use that type of progesterone, but we're probably never going to have a prospective study where we enroll women and say, take this hormone therapy and let me see what happens over the course of your life, that's probably never going to happen again. But we do have some retrospective studies, or where we just do case studies where we look at women who had chosen to be on hormone therapy. And those support pretty much what we say, is that we're not using that same hormone. We're not using the synthetics. We're using more bioidentical at this point. And we're also trying to use the transdermal versus the oral. So there's lots of things that we're doing differently now, which makes us put a big question mark on the whole study. But we do know that, again, we know that estrogen can increase that risk, but specifically when it's taken orally.
Okay.
Yeah, I know
Thank you.
that's a whole lot.
No, that's very
to
helpful, because I think
uncover.
people want to know,
Yeah,
you know,
yeah,
the science behind it, and why, like you said, the medications we use now are very different
totally
than what
different.
was used then. Dosing is different, and
Yes,
um,
yes,
very helpful.
yeah.
Now, you alluded to bioidentical. Now, people sometimes don't think of the medicine they get at the doctor as bioidentical.
That's
So,
true. That's true. So, what labs do I need? Or can I have my hormones checked? Like, that's probably the number one question. But the second question is, do you offer bioidentical? So, that is it
yeah.
across the board. It's probably the second most common question.
Mm.
And I think kind of looking at definitions may be beneficial here. So, after the, I have to keep bringing up the Women's Health Initiative, but after the Women's Health Initiative, we started to see a rise in compounded hormones. Okay. Now, let me just kind of walk through that. Compounded hormone is one that's made maybe in a local pharmacy, where the pharmacist is taking the ingredients that are very similar to what's available at Walgreens, Walmart, or your big name pharmacies through big manufacturers, and they make a specific formula for you. So they will use what they say is, plant-based estrogen, or they'll create this estrogen that works the same in your body. Patients think, because this is plant-based, it's being formulated just for me, it must be safer than the prescription that's written and sent to Walgreens and covered by my insurance. And that, unfortunately, is not the case. That's not true. So a compound makes a bioidentical hormone. That's absolutely true.
Hmm.
But our big manufacturers also make a bioidentical hormone. So the estradiol that I write and send to a local Walgreens, Walmart, big name pharmacy that is covered by insurance, that is FDA approved, it's still bioidentical. It still works the same as your own estradiol, the progesterone as well. It works the same as what you're producing in your body. I think the big difference is, again, they use synthetic hormones in the Women's Health Initiative. So the names of those medicines kind of stuck out with people. It was Premarin, it was Provera. And so they think those are not safe because they are synthetic. Again, we don't usually use those. Our estradiol, you can just use a generic estradiol. It is absolutely the same as what we make in our bodies. And it's not a synthetic. So it is still considered bioidentical. The difference between the FDA approved bioidenticals and the ones that are at a compounding pharmacy are, we get a benefit when they're FDA approved because they have to undergo FDA required testing for safety and efficacy. And so we know batch after batch after batch what's in the medicine, what the buffering ingredients are, the things that are helping it be shelf stable. We know all of those things. We know its half-life, we know its bioavailability. So we know what it's doing in the body because they are identical doses made each time, which is required. When we look at medicines that are made by a compounding pharmacy, month to month, the dosing or the absorption may be a little bit different. And so I might have patients come in from time to time who say, I've been taking this same medicine from the same compounding pharmacy, but the last 3 months it hasn't, I feel like my symptoms are back. Well, is it that the symptoms are back, or is it that now they're using a different medicine, a different component to make it shelf stable? Is it being absorbed in your body the same way that it was before? We don't know because it does not require the testing that the FDA requires. Additionally, the compounded medicines do not get covered by insurance. So those are out of pocket. So again, if you have a bioidentical that's tested, it undergoes this rigorous testing. We know what's in it. We know how it's going to work. We know how long it lasts in the body, and it's covered by insurance. I'd rather go with that versus going with one where we might not have equivalent dosing from month to month and we have to pay out of pocket when you have the exact same medicine that does the exact same thing. Yeah. So it's difficult because I think after the WHI, we label compound as also bioidentical, as also plant-based, as also safer.
Yeah.
And unfortunately, it's not safer. It's bioidentical, but the FDA approved is also bioidentical. And in my opinion, I feel that it is safer because it has to undergo the testing. It's got to get approved. It's got to get approved to be out in the general population. Right. And again, if they do the same thing, why not get the one that might be covered by insurance? Or if we have to pay, it's a minor amount versus what we have to pay compounding. And if you think about pellets too are also compounded hormones. And so those are made in a compounding pharmacy. They're, placed in an office, and patients think, well, these are safe because they're plant-based or they're using all natural ingredients. Again, yeah, they're both bioidentical. With pellets, I probably see more irregular or inconsistent dosing with pellets than I do with the creams and the tablets that are made by a compounding pharmacy. But the thing about a pellet is once it's in, we can't take it out. Yeah. We've got to wait at least 3 months or 12 weeks before we can really do anything in terms of switching treatment or, doing something new. We can't give you estrogen if you just got an estrogen pellet. We can't really do that until we've given it its whole 12 weeks. And so sometimes with pellets, we see more irregular dosing where we get a boost of all the hormone within the first week of the pellet being injected. And then we're stuck for the next 11 weeks not feeling that we're still getting a daily dose of those hormones. And so again, and pellets are, going to be even more expensive, usually about $300 every 3 months versus a medicine that you fill monthly, or you do a 90-day subscription or prescription refill that, again, is usually covered by insurance. So for me, I prefer, if I'm prescribing, to do bioidentical and to do the bioidentical that is usually going to be covered by insurance.
Thank you for talking about that.
Absolutely.
Yeah, that's a big question. We have just a couple minutes left. Can you touch a little bit on testosterone? Because people are talking about it for sure.
They are. So, as a menopause certified provider, when we talk about testosterone, we talk about it in perimenopause and menopause really to treat a specific diagnosis. And that's hypoactive sexual desire disorder. And that's when we kind of notice the changes in libido. It's bothersome. It's been present for at least 6 months, and we want to do something about it. Now, you may see on social media and everywhere else, everybody needs testosterone. Give everybody testosterone. Don't withhold the testosterone. Why can't we get it approved? It is not FDA approved. It's not, even for hypoactive sexual desire disorder, but it is indicated for hypoactive sexual desire disorder. And when we give it, if we prescribe it, again, we're trying to do the safest formulation of it, then what we usually do is the men's testosterone gel, and women only need about 1/10 of that dose. So the men's gel comes in packets, and there's 1 packet a day for them. So 1 box of packets is 30 packets. So for us, if we're only taking 1/10, we usually only need that 1 box. That'll last us 300 days. And that is probably anywhere from maybe about $120 to the most I've seen is $180, again, versus a testosterone pellet, which might be about $300. Now, there are potential side effects associated with taking testosterone. And so this is the one place where a lab is required. So we do check the testosterone level if we're going to prescribe testosterone. And the level is not to see where you are because your testosterone level is low. It's not to check to see if it's low. Most of us are going to have menopausal range testosterone levels. That's what happens. It's again, when we are entering into this phase of life, we're not going to produce quite the same. And sometimes we see a little bit of boost right after menopause where the testosterone level goes up just a little bit because we see some changes in the other hormones that circulate to kind of grab the free testosterone in our bodies. But we check the testosterone level. We want a baseline level because we need to check the level while we're giving testosterone. We want to make sure that we're not bumping that level up to what we call a super therapeutic level or a men's range testosterone. Because when we do that, there are side effects. And some of these side effects can be irreversible. So there can be, deepening of the voice or voice changing. Of course, growing hair in places that are, similar to where men would grow hair. So the chin, the upper lip. Also losing hair in the pattern that are similar to men. So a male pattern type baldness look, acne, oily skin, and also enlargement of the clitoris. And so we want to make sure that we're keeping that testosterone level in range while also reevaluating to see if we're noticing improvement in that sexual desire libido. And if we don't see any improvement and we've been on it for over 12 weeks, some of us will try it at least 3 months. Some will even try up to 6 months where we're keeping it in range. We see the jump. So we see that we've gone from the baseline and we're in range and we're still not noticing improvement. That's when we would say that testosterone may not be the option to treat the hypoactive sexual desire disorder. We also have some prescription FDA approved medicines. And so those are options as well. One of them is an injection. One of them is an oral tablet. So we do have other options. But testosterone can also, give you energy, and maybe you might notice that you are losing weight or you're building muscle. And that is similar to when we take testosterone. Well, not we, but when we've seen athletes take testosterone and be disqualified from certain sporting events because we consider that doping. We consider that, taking the steroids inappropriately. And so, yes, it may make you feel good, especially if you get that little boost initially, but then you will need to continue, and then you will need to continue increasing that dose. So that's why we use it really for what it's indicated for, which is hypoactive sexual desire disorder, and not for energy and building muscle.
Great.
Yeah.
And hoping, of course, that there'll be more research on this.
Absolutely. Absolutely.
Yeah. And also, I know that there are companies who are trying to make formulations for women because honestly, taking a packet and saying use 1/10 of it is not okay.
Well, it's messy. You've got to put it in something else, or it may dry out. And we've got it. It's approved it's been in Australia for years, and I think it might have just been approved in Great Britain. Don't quote me on that, but I think we're seeing the movement to get it approved for use in women, as a dose that we don't have to go and squeeze out a packet and put it in some type of syringe or some other storage thing to keep it from drying out. So
yeah. To come.
Yes.
Great. Well, thank you so much for being here on the podcast today. I know people love to hear this hormone update every year, and I really appreciate your expertise on this.
Well, it was my pleasure being here. Thank you for inviting me.
And as I told you all, Dr. Kerri Anthony is in Oklahoma, but she does menopause care through telemedicine. And we're going to let her tell us what state she has licenses in right now.
Awesome.
So that you can reach out to her. So please go ahead.
So my telehealth company is Your Menopause MD. So at yourmenopausemd.com, also on all the social media platforms. So Facebook, Instagram, and TikTok. But I am licensed in Arizona, Arkansas, California, Connecticut, Georgia, Indiana, Kentucky, Maryland, Minnesota, Mississippi, Missouri, Nevada, New Hampshire, North Dakota, Oklahoma, and Texas. So if you live in one of those states, you can schedule a telehealth visit with me through Your Menopause MD. And the initial visit is a 60-minute, very comprehensive visit. So I would be happy to see you.
Thank you so much. And this is, I just have to say, my personal opinion is this is so much better than the hormone telehealth big platforms that you don't really get the personalized care. And if you need to go to that, But
absolutely.
But this is so much nicer to get to actually spend time with your doctor. So
yes.
Great. And we will make sure that Dr. Anthony, all her links are in the show notes so that you can find her easily. But we wanted her to say out loud what those things were so that you will know.
Yes. Awesome.
All right. Thanks again for being here today.
Thank you for having me. Have a great one.
Hi, this is Dr. Heather Awad. When people find out that I coach professional women in the menopause transition and beyond to lose weight for the last time, the most common question I get is, What should I eat for breakfast? And I got this question so many times that I created a guide to make this really easy for you. In it, you will find doctor-approved ideas for that first meal of the day and a really flexible formula that you can use over and over again that will really help you with your weight loss journey. If you would like this, go to vibrant-md.com/breakfast.